All right. So it's my pleasure to introduce the moderator for our session entitled Emerging Areas in Pharmacogenomics. Dr. Jeff Bishop is the moderator for this session. He's an associate professor in the Department of Experimental and Clinical Pharmacology. And Dr. Bishop's area is pharmacogenomics in the mental health space and in particular depression. So I'll turn this over to Dr. Bishop.
All right, hopefully everybody's refreshed after a nice break. It's really my pleasure to moderate the session on up-and-coming areas in pharmacogenomics. We've got two exciting speakers today, one in the area of pain management, and the other in population and ethnic diversity and how we consider that in pharmacogenetic studies. Our first speaker of this session is Dr. Gillian Bell. Dr. Bell is interim director of Pharmacogenomics and Personalized Medicine Program at the Mission Healthcare Center. She is also an assistant professor of clinical education at the UNC Eshelman School of Pharmacy. She completed her Doctor of Pharmacy training in Tennessee and then went on to receive additional postdoctoral clinical training at the Tennessee VA as well as the St. Jude's Medical Center. And she has really been one of the field leaders in applying pharmacogenomics in the front lines of clinical care. And one of those areas is related to pain management. So it's really a pleasure to have Dr. Bell here. So please join me in giving a warm Minnesota welcome to Dr. Bell.
Thank you. Can everyone hear me? Okay, good. I want to thank the organizers for inviting me here today to speak to you all about using pharmacogenomics and pain management. And we actually got a really great introduction to this topic from Dr. Johnson in her talk this morning. So I'm just going to continue along that same theme. I don't have any conflicts of interest to disclose. So millions of people suffer from acute or chronic pain each year, and actually pain affects more Americans than diabetes, heart disease, and cancer combined. We know that it is costly to treat pain. It's estimated that more than $600 billion is spent annually managing chronic pain. We know that opioids has been in the past a big cornerstone and a big modality that we use to treat pain. There are a lot of things that are changing in our current climate, but opioids are still going to be something that we use to treat moderate and severe pain. In 2013, 249 million prescriptions for opioid pain medication was written by healthcare providers. That's about enough for everybody to have their own bottle of oxycodone or hydrocodone. We also know that overdose deaths involving opioids has gone up dramatically in the last 20 years. And that's from any opioid, that's synthetic opioids, and we're also seeing a big rise in the use of heroin. And I don't know about you all in your communities, but this has really rocked Western North Carolina. It's been a big impact in our emergency departments and in our health system of trying to care for patients that are coming in with overdoses. If we look by the numbers, in 2016, 116 people died every day from opioid-related drug overdoses, and a little less than 50%, around 40% of those were from prescription opioids. 11.5 million people misuse prescription opioids, and I'm not going to go through all these statistics, but they're pretty staggering. So because of this crisis, there's been a big push from our government to try to get a handle on this. The U.S. Department of Health and Human Services, they've outlined a 5-point plan for fighting the opioid crisis. And I'm not going to focus on all of these in this talk today, this short talk today, but I do want to focus on these last two or just highlight them. So providing support for cutting-edge research on pain and addiction. I think we're going to see a lot of research on pain and addiction, and I think there's already a lot of research in genetics and how it can affect pain and addiction. I think that's one of the #1 questions I get asked by primary care providers in my area is, do we have any genetic markers that could help me predict if someone might become addicted? I don't think the evidence is there yet, but I think it's an active area that we're going to see. Also, advancing better practices for pain management. I think this is where genetics and even pharmacogenomics could come into play. So we know that we want to prescribe the lowest possible effective dosage of opioids if we're going to use them. And so I think pharmacogenomics could help in this realm. And then prescribing guidelines, evidence-based methods of pain management is definitely another area that pharmacogenomics could touch. And as we're starting to move away from just opioids for chronic pain and we're starting to see other modalities and other medications being used, we also have to realize that pharmacogenomics can affect those other medicines as well. So pain is a really hard topic to study, and that is because there are so many factors, genetic factors and non-genetic factors, that can affect how we respond to opioids. So if you see up at the top here, non-genetic factors, it can be age, sex, drug interactions, ethnicity, race, and an even bigger area that I think there's a lot of research right now is psychological. So anxiety, stress, adverse childhood events, all sorts of things. Now, we know that some of these non-genetic factors have genetic links, so that even adds another level of complexity to it. But if we go down here and focus on genetic factors, and really, I like to divide this up into two thoughts, and this does a good job in this figure. So pharmacokinetics and pharmacodynamics. So Dr. Johnson already kind of outlined this morning a lot that we have in pharmacokinetics, and I'll be focusing on that today as well. So drug metabolizing enzymes, CYP2D6 being the major one that we have guidelines. We have a lot of information, but there's a lot more that are being studied. Also transporters, ABCB1 is one that has been studied heavily. But then when we move over into pharmacodynamics, so then we're looking at pain sensitivity, efficacy of these pain medicines. This is a really tricky area, and there's a lot of research, and I'll try to highlight some of it, but I still feel like it's a bit of a moving target, and we haven't quite settled on what to do with all of that yet. So cytochrome P450 2D6 or CYP2D6 involved in the metabolism of a lot of medicines, including some of our commonly used oral opioids, codeine, tramadol, hydrocodone, and oxycodone. It's a very highly polymorphic gene, over 100 known variants, wide variety of enzyme activity, and here I'm going to go back to this same slide with codeine metabolism. This is from the CPIC guideline for codeine. We know that codeine is converted by CYP2D6 to morphine, and that's where we get our analgesic activity. Morphine has 200-fold higher affinity for the mu-opioid receptor than codeine, so you really need CYP2D6 to be able to make that conversion in order to get pain relief. So we have a CPIC guideline for that, and I'm not going to go into great detail about this, but we divide people into these different phenotypes: ultra-rapid, normal, intermediate, and poor. I will say that normal and intermediate metabolizer, that's a bit of controversy in our field. I think we're going to have, there's a working group that's working on, trying to really discern between normal and intermediate. Because we're looking at kind of a continuous variable of an activity score, we have to create cut points to put people into these groups, and there's some controversy around that, but we should have some more clarity coming soon. But basically, people that are ultra-rapid metabolizer have increased activity, and those with poor have low or no activity. So when we look at what we need to do for codeine, for ultra-rapid metabolizers, we're going to have an increased risk or increased formation of morphine. They could be at a high risk for toxicity. So per CPIC guidelines, avoid codeine due to potential for toxicity. Consider alternatives that don't go through CYP2D6. This is a strong recommendation. Then I'm going to jump down to poor metabolizers. They're going to have reduced morphine formation. They could have insufficient pain relief. And so again, avoid, but this time due to lack of efficacy. But what about our other commonly used opioids that we see every day in our practice? So as Dr. Johnson alluded, oxycodone, it actually goes through a couple different pathways, not only CYP2D6, but also CYP3A4. We know that the pathway through CYP2D6 converts oxycodone to oxymorphone, and it has a much higher affinity for the mu-opioid receptor than oxycodone. So that is really the main pathway that you're wanting in order to get the most analgesic activity. If we move down to hydrocodone, Similar story, it goes through CYP2D6 to form hydromorphone. It has a much higher affinity for the mu opioid receptor, but oxycodone and hydrocodone as a parent compounds, they do have some analgesic activity, which compared to tramadol and codeine, where the parent compound really doesn't have that much analgesic activity. And as we talked about earlier, tramadol really highly relies on that to become a much more potent metabolite. And so when we look at what the guidelines say for alternative opioids, we know that for ultra-rapid and poor, alternatives not affected by CYP2D6 would be optimal, but tramadol, to a lesser extent, hydrocodone and oxycodone aren't good alternatives because of the CYP2D6 pathway. Same thing for poor. Now, I do want to highlight here that in the CPIC guideline, it goes on to say that there's insufficient evidence whether PMs can be expected to have decreased analgesia or whether UMs have increased risk of toxicity. So really just highlighting that the data aren't as strong for oxycodone or hydrocodone, but definitely for codeine and tramadol, we know what to do. So it would be up to our own clinical judgment as to what we want to do with oxycodone or hydrocodone, and hopefully we're going to have more data coming out from groups like University of Florida really giving us more guidance. So now that I've really focused on what we have lots of data for, what about emerging genetic variations like OPRM1? So this gene encodes for the mu opioid receptor, and this is where our opioid medications go and bind. There are more than 100 SNPs that have been described, and the most widely studied is this particular A change to G at the position 118. The frequency of this SNP really varies among races and ethnicities. Here I'm showing that 4% in Africans have 1 or 2 copies of the SNP, and 15.4% in Europeans and 48.5% in Japanese. So really wide variety there. This gene and this gene variation has extensively been studied with morphine compared to other opioids, although there are some studies out there. And what numerous studies have reported is that if you have the presence of that variant, it's associated with a reduced analgesic effect. So when we look at, especially in the post-operative group, that they have higher post-operative morphine requirements, or they have higher consumption of morphine after surgery. And higher doses of morphine in our cancer pain population, we've also seen that higher doses of morphine have been needed with those that are homozygous for that variant. But then in the same vein, we have plenty of other studies that have failed to show an association between genotype, pain scores, and also dose requirements. So I know there's a lot on this table, but I'm going to walk through it. Basically, I'm focusing on post-operative pain studies here. And as you can see, mainly morphine is the majority that's been studied, but also fentanyl and oxycodone. So lots of different variety in what's been studied. When we look at the study population, it's really heterogeneous and really variable. So when we're looking at lots of different types of surgeries, some of these in this table were hysterectomies, some were appendectomies, some were people that had knee replacements. And so really, really lots of different patient populations being studied. Also lots of different race and ethnicities. If we continue, we've got lots of different routes that we're giving the medication. And when we look at the results, it's I don't want to say it's half and half, but it's really split down the middle, that it's no difference in pain scores and morphine doses, and then some show differences in pain scores. So basically the majority of these studies, they were looking retrospectively after surgery, and in a 24-hour period, they were recording pain scores and also how much morphine equivalents they used, and then they were using that to try to create associations with the OPRM1. So we have a lot of conflicting results here. Some other emerging genetic variations, ABCB1, which is a transporter I mentioned earlier, and also COMT. So ABCB1 encodes the ABCB1 transporter. It's also known as PGP or MDR1. This is present in the GI tract, liver, kidneys, and blood-brain barrier. It facilitates absorption, distribution, and elimination of opioids. including fentanyl and morphine. And what we're seeing is that impairment may result in increased bioavailability of oral meds. We might have decreased renal excretion, and we might have increased CNS concentration. It is also highly polymorphic. More than 100 SNPs have been described. And of course, we have one that's been the most widely studied, and it's listed there. COMT, or catecholamine O-methyltransferase, it's an enzyme that's involved in the metabolism of catecholamines, and those play a role in pain modulation. So impairment of this enzyme can result in increased concentrations of dopamine, which you have increased concentrations of dopamines that can suppress endogenous opioids, and that results in upregulation of our opioid receptors. And so for this, the most widely studied SNP is this Val-158-MET, so a change in protein there, and it's at the position RS4680. So I'm going to walk through, and we have much fewer studies for ABCB1 genetic variants. So we have a study here with experimentally induced pain, and they saw a difference in this experimentally induced pain and the discomfort and pain rating during this very specific type of test. When we look at post-operative studies, lots of different medications used and not very many studies. Not only did they look at the the common variant C3435T, but also looked at other variations. We have, across the board, no difference in pain scores and consumption. If we move down into the cancer and chronic pain, non-malignant conditions, we have very mixed results here, various things being studied, various different types of patients, and not only just a few SNPs, but lots of SNPs being studied. So if we look at all of that and take that all together, still very conflicting results. When we go through COMT, we have some results from experimentally induced pain. This is looking at healthy subjects, and they didn't see a difference in analgesic response. I think that's a way to study pain, but it's not very realistic for how we're going to use it in our patients. Post-operative, not very many studies, but looking at morphine and oxycodone, with the biggest study at the bottom with oxycodone looking at 22 different single nucleotide polymorphisms in COMT. They did not find a difference in consumption. And then when we look at cancer pain, this is where we actually do see 3 studies that have a difference in requirements with COMT, but then we have other studies that show that there's not. So once again, very mixed. And it's probably not just going to be one of these markers. There actually are studies out there where they looked at the combination of OPRM1, ABCB1, and COMT. And so I think we're going to see more and more studies that are looking at these genetic variations that probably play a modest, multiple variations that have a modest impact on our pain phenotype, our analgesic phenotype, but we need a lot of those to actually get the impact size to affect patient care. Okay, so I'm going to go through a quick patient case. This is something that I like to use with my pharmacy students when we're starting out talking about pharmacogenetics. So we have a patient here, is a 25-year-old who had an outpatient dental procedure. He comes into your retail pharmacy, and he has a prescription for Tylenol number 3 or codeine with acetaminophen. He's taken codeine in the past. It didn't work. He didn't have pain relief. He tried to double up in the dose, and it still didn't work. He's had PGX testing done through his primary care provider and wants to know if you could help explain this. And you see that he has a CYP2D6 result of star 4, and the interpretation is poor metabolizer. So I feel like we know what to do with this. This is a case we can do something about. So if we go back to our CPIC guidelines, we go down to poor metabolizer. Recommendation is to avoid codeine due to lack of efficacy. And then we have some alternatives that are suggested there. I would like to propose this patient case. So this is based on someone that I saw in my pharmacogenomics clinic, and I feel like this is a little bit more real world for what I live in. So we have a woman here, a 45-year-old woman who has Ehlers-Danlos Syndrome, fibromyalgia, she has migraines, ankylosing spondylitis, and cervical spine instability. And Ehlers-Danlos Syndrome is it has to do with hypermobility and connective tissue. These people have a lot of pain, and they have a lot of issues trying to manage their pain. She's had multiple surgeries in the past. She's got an upcoming surgery scheduled for a fusion. She had terrible pain control with the previous surgeries. She's really, really anxious about the upcoming surgery. She's reported really severe side effects in the past, feeling like her respiration was depressed, severe nausea. She passed out. She had an adverse reaction reported of passing out to tramadol. So she's had pharmacogenetic testing done, and she wants you to review it. So when we look here, I'm going to highlight there's a lot of results on here from her panel test, but I'm going to highlight that she's a CYP2D6 normal metabolizer. For OPRM1, she is heterozygous for that A118G variant. And then for COMT, she's also heterozygous. So she's got one Val and one Met allele. So what are we going to do with her? So when we looked at her medication list and we looked for the plan, her pain plan for surgery, they already had a really great outline plan based on what's happened to her in the past clinically. They were going to use a fentanyl patch. They were going to consider really hydrocodone liquid, low dose for breakthrough pain, because even with low doses, she had really severe side effects in the past. And then also consider some non-opioid analgesic medications. And so from our pharmacogenetic results, we didn't actually have a lot to add to this pain plan. But I will tell you from speaking with her, she was actually really excited to have someone go through the results with her and have someone look at these results. And she felt more confident going into her surgery, knowing that there just wasn't something lingering out there that we weren't addressing. And so even though with those variations in OPRM1, with the variations in COMT, and no variations in CYP2D6, I feel like we were able to help her with these results. And so I think we've already heard a little bit today that it's not all about just the impact we can make, but also, the recommendations we can make for different therapies. It's also how we can help patients navigate through pain. So in summary, treating pain in the opioid epidemic is costly and time-consuming. Genetic variation can account for up to 60% of the variability in opioid response. There's many non-genetic factors. That's why it's such a difficult thing to study and a difficult thing to utilize. Associations with metabolizing enzymes, specifically CYP2D6, are well studied and actionable. We do have CPIC guidelines for those. I think variations in pharmacodynamic targets are evolving, but difficult to implement broadly at this time. But can be an additional tool in certain circumstances. I think we're going to see a lot more, we're going to have a lot more studies of using this information up front. And I think that's going to be very helpful in how to use these. I also feel like we could carve out pockets of patients that are going to receive opioids, and it can be very helpful. At Mission, we have started, we're going to start a pilot study utilizing pharmacogenetic testing in our palliative care clinic. And so I feel like that could be really impactful in a very certain subset of patients there. We also did a supportive care study at Mission Health where we tried to utilize pharmacogenetic testing for our patients who are embarking on chemotherapy and trying to use the pharmacogenetic test results for pain, not only pain, but also anti-nausea and even behavioral health medicine. So I think we're going to start seeing this used more and more in various subsets of patients. Okay, and with that, I will take questions. Thank you.
So the genetic variants, as we know more and more about how you might treat pain, might well be a very different issue than anything that we might understand in the genetics of addiction. Or is it different?
I'm sure there's some, there's going to be some intertwining or overlap, but yeah, I think that is going to be very different. And I think the genetics of addiction, that's just, to me, that's a very interesting thing to start trying to utilize genetic markers to predict people. I think we have some clinical tools that we're not even really using that much widespread. for addiction. And so I think it's probably going to end up being a combination of clinical tools and maybe some genetic markers. But I think we have a long way to go as far as the addiction.
Is there any evidence that the requirement for increased dosing has a higher risk for addiction?
I can't speak to that. I don't know right off the top of my head, but I don't know if anyone else has that.
Hi, this is Allison Quinn. I just wanted to ask you a question about the OPMR1. Mm-hmm. You noted how it's pretty wide, ethnicity really plays a role in how common it is. So does this mean, in terms of studies, that the effect of the gene can potentially depend on the ethnicity, like we see with SLC6A4? Mm-hmm.
So I think if we looked at the postoperative pain, and if we actually went and dissected all of those, I think that there was an association between ethnicity and that seeing a difference in pain scores and consumption. So there I do believe there is an ethnic trend there. Yeah. So yeah, it does exist. I just feel like it's still, even within that subset, it's still very conflicting and lots of different things being studied. So.
Okay. So, for instance, in Japanese patients who are more likely to have the variant, was it seen that they had an effect more from this, or the opposite?
I don't know specifically about that very specific group. We'd have to go back to that whole thing and dissect everything. But I do know that ethnicity, there was a trend where they saw more differences in different ethnic populations. So,
thank you.
Mm-hmm.
Stephanie Huang from University of Minnesota. One question, you sort of alluded to multiple genetic variants could affect the same phenotype. Is there any effort right now to try to combine the PK, PD, or not just a small part of it, but say developing some modality for combination of genetic risk in predicting pain?
I think there are plenty of studies that have looked at that retrospectively. I think we do have some that are looking at it prospectively, but I don't know of a robust amount that has really clean results of looking at all of those together. Yeah, and it's going to be small amounts of patients being studied, and also kind of if you're looking at COMT, ABCB1, and also OPRM1, we're looking at really small subsets of patients that are going to have all of those combinations together. So I think we have small numbers right now.
What do you see? The future research is just one gene at a time, and every gene has a small effect? How are we going to apply this in the clinic?
I agree with you. I think we're going to have to start looking at larger amounts of, like you said, small effect size genetic variations, and create kind of, I don't want to say algorithm, but some sort of pain or some sort of score that would put people in those categories. And then once we get to those, we need to kind of prospectively apply that.
Thank you.
Hey, quick question on, maybe it's not quick, but a pragmatic study using administrative claims data. Excuse me. Administrative claims data, I mean, we know from our 15 million commercially insured lives of Blue Cross Blue Shield that 1 in 10 people have an opioid claim in any given year. So knowing that we have this subset that are poor metabolizers that are less likely to have a euphoric effect from their opioids, and then there's ultra rapid metabolizers that are more likely to have a euphoric effect, is there potentially a relationship between the risk of dependence and claims data showing the use of treatment by your genetic testing results? Has anything like that been done?
Not to my knowledge.
Yeah, I mean, I think that's a great opportunity if you had genotype data and claims data. There are some small studies from probably the 90s documenting or suggesting CYP2D6 poor metabolizers don't get addicted. Right? So not only don't they get pain relief, they don't get the euphoric effect. So there probably is some link. I mean, clearly that's not the whole story to addiction, but if you had genotype data, you probably would see that the PMs are seeking a lot of care related to their pain, but they're also not getting addicted.
Because it helps justify from the payer perspective this pan testing we're talking about, or at least people would like to see happen. I mean, the payers want to pay for pan testing, but we also need to have rationale. And if I mean, we're building predictive models right now with our databases that don't have genetic data in it, and then we're putting forth interventions to providers. I mean, we're being asked by that from self-insured employers. So, I mean, this is what's happening right now in the real world, and so it would be helpful if we could get some data to justify that, at least from a predictive model standpoint, we can do a lighter touch to people if they're a poor metabolizer, and maybe a heavier touch because there's some, at least, pragmatic real-world data that suggests those types of those differences.
All right, we'll do one more quick question from Josiah.
Hey, Josiah Allen from Metagenesis Consulting. Just a quick question. I thought the point that you made towards the end of that first case was really interesting, or the second case actually, where everything came back more or less normal, and almost that you use that as sort of a rule out of a metabolic issue rather than as a rule in. I thought that was a really critical point and something that often gets overlooked. We're always looking for the poor metabolizers or the ultra rapid metabolizers and ignoring the potential benefit of a rule out in the normals. I was just trying to think of a way, because one of the common criticisms of pharmacogenic testing is, you're focusing on these small subpopulations, and so how is it beneficial to a large group of people? Do you have any thoughts on how we might be able to quantify that in a way to prove some value to that?
I don't have some thoughts on how to quantify that. I can just speak anecdotally from the patients that I've seen and have tested, that a lot of times that ends up being a really important point to them. So I don't know if there's a lot of us out there that are doing this that could kind of pull that data, or if that's something that when we're talking about IGNITE trials, we need to include that or somehow capture that, but yeah.
All right, well, thank you so much. Join me in thanking Dr. Bell for a nice talk.